Hello and welcome to this live stream event provided by LE&RN. I'm Guenter Klose. I'm a lymphedema therapist and instructor for now more than 30 years. And I would like to take a moment to thank LE&RN for providing me with this opportunity to talk to you about a topic that I'm very passionate about, and that's lymphedema therapy and complete decongestive therapy in particular. I feel that there's a lot of misconceptions about the delivery of lymphedema therapy and CDT in particular. And I'm hoping that a lot of lymphedema therapy providers have tuned into this live stream or will take a moment to look at it later when it's archived on the LE&RN website. I would like to give you a heads up that this presentation has been pre-recorded, but I'm available for Q&A right after this presentation. So please post your comments, post your questions here on this website, and we will be answering it right after this presentation. Despite the fact that there is an increased number of surgeries provided to patients with lymphedema, CDT remains the standard of care for patients with lymphedema. And CDT is very well described in the literature. It is a treatment that consists of 4 components: skin care, manual lymph drainage, compression therapy, and exercise, which, if applied in combination and in the correct frequency, results in very effective treatment for patients with primary and secondary lymphedema. Instructions in self-care, of course, are also part of a comprehensive CDT protocol. CDT is a 2-phase therapy, one being the intensive or decongestive phase, which is performed by a certified lymphedema therapist, and phase 2, which is carried out by patients as part of their daily maintenance routine. We call this phase 2 of CDT the self-care phase. It is that interplay of the intensive phase of therapy with the self-care phase which makes this treatment so very effective and assures that the therapy is successful in the long term. Mind you that most patients with lymphedema do not know what a proper CDT protocol consists of. And they have to trust that this lymphedema therapy provider they see will provide the best, highest quality lymphedema treatment available. And just to reiterate, in order to be successful, patients and therapists alike need to adhere to the CDT protocol. No component can be left out, no shortcuts can be made, or you're simply not performing CDT. I would like to take a moment and remind you of some of the challenges that we face in lymphedema therapy. And that's important before we go into talking more about the treatment. One of the challenges that we face in lymphedema therapy is that it is a chronic and progressive condition. Lymphedema always starts with lymphatic impairment, which soon allows protein-rich fluid to accumulate in the tissues. This protein-rich fluid triggers a low-grade chronic inflammation. I'm not talking about infection such as cellulitis, but a very low-grade inflammation which triggers secondary tissue changes. Fibrosis develops and the skin and subdermal tissues become thicker and indurated over time. There's also more or less adipose tissue proliferation in the affected area. This adipose tissue expansion is not only an issue of size or weight of the affected extremity, but also affects the integrity of the lymphatic vessels that are still working, which as a result leads into more lymphatic impairment. Especially in the lower extremity, many patients develop significant skin changes, which makes patients even more prone to developing potentially life-threatening infections. And you can see how this cascade of events turns into a vicious cycle, which continues to exist despite the best therapeutic approach. It is very important for us at all times that we keep in mind that lymphedema by nature is a chronic and progressive disease. Another challenge is the number of therapies that have been suggested for patients with lymphedema over the years. Just take a look at this flowchart, which I created based on the International Society of Lymphology consensus document from 2016. Some of the treatments listed here should clearly be seen as an adjunct to lymphedema therapy and not a standalone treatment. But the fact that so many therapeutic approaches are offered causes increased confusion in the medical community and by patients who are browsing the internet for help. They simply don't know which treatment or combination thereof is the correct one for them. I am the first one to acknowledge that there is no cookie-cutter approach to the treatment of lymphedema. No one-size-fits-all approach should be used. Each of the patients shown here has their own unique set of complaints and need for treatment, and should be treated in accordance to the severity of their lymphedema, with appropriate consideration given to any comorbidities that might exist. But the fact that we need to customize the treatment to each patient's individual needs should not give us permission to shortcut the treatment and then ultimately shortchange the patient in the care that they need and frankly deserve. And remember, this is all about patient care. And I would like to remind everyone that lymphedema is more than just a swelling of an upper or lower extremity. Lymphedema affects an entire person, and most often their entire family. So in the next 2 minutes, let's meet some patients, some persons who are affected with lymphedema. Can you both just say hi?
Hi there. Hi. Hi.
It all started when I was diagnosed with breast cancer in August 2012. I immediately went into chemotherapy that was followed by surgery and then radiation.
I do think there was probably issues that started well before then, but when I was 23 is when I noticed some serious problems.
I had 2 cancer treatments, and the second one is when they took out a bunch of lymph nodes, and after that time I was starting to get minor swelling in the leg, and at that time nobody really knew what was causing us, I guess.
Through high school, or even preteen, I always carried a bit more weight than my sister. I have a fraternal twin sister. She was extremely thin, so there was that always constant comparison.
Well, I had a bilateral mastectomy in 2013, and they took 3 sentinel lymph nodes from my right side where the cancer was, and 10 from the left side, which had no cancer.
It was 1982. I was in high school, and it suddenly just started, the right leg started swelling first, and I didn't know why.
It all began with being diagnosed with metastatic melanoma, which is the primary reason why I was seeing doctors.
They just kind of blew it off as insignificant, like it was really no problem, but it really is a problem. It's a daily problem we have to live with.
Yes, so I was diagnosed in 2014, but really started seeking my first help when I was 13, so it'd be 29 years ago.
In addition to what you have just seen, lymphedema doesn't only pose a physical, emotional, psychosocial burden on patients with lymphedema, but also a tremendous economic burden on patients with lymphedema. So at least give them the peace of mind that when they sign up for receiving lymphedema therapy with a CLT, that they will receive the best care that they need and frankly deserve. So let's take a look at what's working and what's not working in lymphedema therapy. This is a very simple diagram of an MLD sequence in a patient with left upper extremity lymphedema. But nowadays we hear from patients who receive manual lymph drainage only on the affected extremity, without prior clearing of the unaffected areas and the adjacent trunk quadrant. Other patients tell us that they are only treated in a supine position and the posterior upper quadrant is completely neglected. This is very inadequate manual lymph drainage, and you are not performing CDT. And this is an example of an inadequate manual lymph drainage. You have to agree this is not working and that our patients deserve better. Many of you have seen the beautiful indocyanine green images and how we are now able to demonstrate lymphatic uptake in the collecting vessels in real time. But if your manual lymph drainage looks like this one demonstrated here, it will not have the slightest effect on your patient with lymphedema. And you are wasting your patient's time and money. The pressure is too light and not even the whole surface of the therapist's hands are utilized. This is very inadequate lymphatic drainage. Effective manual lymphatic drainage will stretch the patient's skin and subdermal tissues, stimulate the collectors, and reroute the fluid into unaffected areas of the body. Occasionally, we need to incorporate even deeper techniques to soften fibrosis and mobilize fluid. MLD alone is also not working. This patient here was treated with MLD repeatedly for about 10 years with no results. Here is the same patient after 3 weeks, 4 treatments per week of CDT provided by an experienced CLT certified lymphedema therapist. This picture and comparison alone should convince even the most skeptic that CDT is a very effective treatment for lymphedema when provided correctly. Now, I don't have any scientific research that shows how long an MLD session needs to be in order to be effective. And we rather rely on our extensive clinical experience. Remember that patients with lymphedema also need to be treated in unaffected areas of their body and the affected trunk quadrant. 20 minutes of MLD is not just pushing the envelope, it just simply does not work. Many facilities have now cut the therapy time for patients with lymphedema down to 45 minutes. And not even the most experienced, skilled lymphedema therapist would be able to provide adequate, effective CDT in this time frame for patients with lymphedema. Some facilities have gone back to treating patients with pneumatic compression pumps and bandaging. This is also not working. Compression pumps may be very helpful for patients in the self-care phase of the treatment, but should not replace expert lymphedema therapy in hospitals or treatment facilities. In my opinion, this is not even close to providing expert lymphedema care. and this is not working. So let's take a look at CDT and what is and how it should be working for patients with lymphedema. The proper CDT protocol, phase 1, asks for daily treatments. That would mean 7 days a week. However, it is my clinical experience that every patient benefits from a 1 or 2 day rest after 5 treatment sessions. CDT is a demanding treatment, and patients will do well for 1 or 2 days without the treatment, provided that they are able to keep their compression bandages in place for that time. If you perform 5 days a week, the treatment would then be carried out for 2 weeks or 3 weeks and then taper down to 3 times per week. And at this point, the patient should be able to receive their custom daytime garment and perhaps a nighttime garment as needed. It is my experience that the phase 1 CDT treatment works best in this type of setting, and it assures that the patient still is motivated to perform their self-care afterwards. So what happens if you treat your patients only twice a week? When you treat the patient twice a week for lymphedema, there's at least one gap of 3 days between treatment sessions in which patients oftentimes lose a lot of progress. They are unable to keep the compression bandages on for that period of time, and it is as if you took 2 steps forward in each treatment and then a step and a half back between sessions. And that will drag out the treatment time for that patient and will be many, many weeks before the patient is able to receive their custom garments and be discharged from your program. Now, I am aware that you are concerned about the limitations in our healthcare system, and that is the reimbursement for treatment and supplies, out-of-pocket expenses, treatment caps, and then after all, there is a perceived productivity of the therapists. But let me give you some food for thought. Here is an informal comparison of the treatments provided by a lymphedema clinic versus a hospital. And this comparison was made by one of our instructors, Linda Hodgkins, who works in Connecticut. And she, in her private clinic, provided the treatment 5 times a week, typically for 2 weeks, maybe 3 weeks before it tapered off to 3 times a week until the patient received their custom garments. The hospital, in comparison, was seeing the patient twice a week, and that would mean that it would take about 8, 9, maybe 10 weeks or more before the patient was ready to be discharged. But here's the interesting part of this comparison. The average total number of visits was 13 to 15 in the private lymphedema clinic and 17 in the hospital setting. The overall reduction, the treatment results, and the adherence to the program and subsequent self-care for the patient was way better in the lymphedema clinic by comparison to the patients who were discharged from the hospital. So when you look at this in comparison to you have fewer visits total, but better treatment outcomes if you treat the patient more consecutively in phase 1 CDT. It is very evident that even patients with mild lymphedema benefit from an intensive 5 times a week CDT phase 1 protocol before they then take over the self-care phase and start managing the condition on their own. Now, one question that we always get from students is, what if my patients do not want to come 5 days a week. Or my favorite yet is, it is not practical for patients to come 5 days a week. Now, let me apply this way of thinking to a patient who is on dialysis, or the diabetic patient who needs to inject insulin on a daily basis. It's not practical to have any kind of medical condition. However, I feel that it is our obligation to lay out the treatment to the patients the way it is most effective to them, and at the end will save them cost and time, because we have provided it in a setting that was appropriate for them. Now, the following is a short interview of a patient who has gone through lymphedema therapy for about 5 years. But I would say, and you will hear that in the interview, that this patient was misguided for a number of years and now is questioning why she was never introduced earlier to a treatment protocol that made an enormous difference in her condition.
For 3 years, I would go to therapy, and the therapy would be twice a year. Usually I'd go for 6 to 7 weeks at a time, and I'd have manual lymph drainage 2 times a week. As a patient who's never heard the word lymphedema, I didn't know anything about it, so I trusted that this was what needed to be done. During this time, I don't remember anyone ever sitting me down and saying the best and really only treatment for lymphedema is complete decongestive therapy. If they did, and they might have, it didn't sink in how important that was to me. I had a very demanding job at the time. I was still working, and so it never was fully discussed. I really wish now that someone had sat me down, looked me straight in the face and said, this is the only thing that's going to help. But that didn't happen. So for 3 years, this is what I do. Twice a year, I'd go in, I'd have manual lymph drainage twice a week, and then go on. 6 months in, I was fitted for custom compression garments, and I wore them faithfully. I had the night garment, I wore that faithfully, and that was my life. I had learned enough to actually start to ask more questions. And although I think I'd convinced myself that maybe my lymphedema wasn't really all that bad, I started to wonder why I had never gone through all this wrapping I was reading about. So I asked the therapist, who had not been my first therapist, and she said, "You were never wrapped?" And I said, "No." And I said, "Can I do it now? Would it make a difference?" So there was a different therapist there that did the wrapping, and I was wrapped for 2 weeks. I left again on a boat in September for 8 months. And while I was away, I decided that I was tired of it felt like I was just swimming upstream. And I really felt that I had wasted a lot of years, that maybe it would have never progressed farther if I'd had better treatment right from the beginning. So I went back for the therapy, and this time to a different place, different therapist. And the wrapping was different. The wrapping was more meticulous, more thorough. The foam wasn't just a rectangular strip wrapped around my leg and then wrapped on top of it. It was fit to my leg. A great deal of attention was paid to my specific areas. There was a greater time period allotted to get it done in. I think everything was fitted more to me, and it didn't slide down as easily. It was just more meticulous and done better. My toes were wrapped, which before my toes were never wrapped. It just felt like a different experience. And sure enough, after 2.5 weeks, my leg was dramatically smaller. And I felt like, it's taken, 5 years? But I finally think I found the answer. I just feel almost distraught sometimes when I think that, I really think a lot of years were wasted. And I don't think it's my job as someone newly diagnosed with lymphedema to know what my treatment should be. And I wish so much that someone had sat me down right at the beginning and said, this is what you have to do. I would have moved heaven and earth if I had known then what I know now. to fit it in with my job, to take another 2-3 weeks off if that's what it was necessary. Because there's no other way around this. This is for life. It's almost worse than the cancer. And I feel kind of terrible saying that, but I know I'm not alone because there's just no way out from this. We need better treatment and better advice right from the beginning. And I would say any patient with cancer or anything else that results in lymphedema, they deserve to know what the best treatment is, not just what might fit with their schedule or with someone else's schedule. It makes a difference.
Another consideration in the treatment of lymphedema is the expenses and the out-of-pocket expenses for each patient. And I do get the question a lot, what if my patients cannot afford the expensive co-pays, or perhaps pay more for a custom stocking instead of an over-the-counter product? Well, my first immediate follow-up question would be, have you asked the patient what they can afford? Have you given them a chance to make a decision on their own? Or was that decision that they can't afford the co-pays and the treatment supplies that they deserve based on your observation and assumption? I know that there is a lot of financial hardship of patients with lymphedema, but we should simply not make assumptions for them. They may have some resources that we don't know of. We can guide them to maybe tap into resources of the local hospital. Sometimes hospitals have funding for indigent patients. We can hook them up with cancer support groups or the Susan G. Komen Foundation if there are breast cancer related patients with lymphedema. Or you can simply go and start a GoFundMe page. There are ways of helping those patients to establish the resources that they need for treatment. And if you think back a little while, when I explained the treatment comparison in the private clinic to the treatments that were provided in a hospital setting only twice a week, the overall number of treatments was less. So the co-pays will be less if you do it more consecutively and you perform lymphedema treatment the way it should be performed. Now, every time I do a presentation or I teach a class for lymphedema therapists, I do get the question, where is the empirical evidence? Where is the research that tells us what effective CDT must be like? And there's a very casual, perhaps non-satisfactory to some of you answer, and that is, if it were easy, the research would already been done. But you can tell there's too many variables in our patient population and too many variables that we need to account for in the treatment of lymphedema. We would first have to phenotype patients and make sure that we are grouping the patients and that they are all the same age, their same body type, their same weight and height, etc. In addition, we know from research that some patients are more predisposed to developing lymphedema. And so for someone who has developed breast cancer-related lymphedema, you now have to do some genetic grouping and making sure that this is all appropriate and that we have the right comparison. And when it comes to treatment, I just want to say, think back a few minutes ago when I showed you the comparison between effective and ineffective MLD. Now you would have to have the same therapist providing the same high-quality manual lymph drainage on these patients in order to have a good and meaningful comparison, because all these variables need to be, if you will, calibrated to offer the same treatment to patients over a period of time. And perhaps if you want to do it in a double-blind way and, swap the patient groups. You would have to have some washout period and do it all over again. In other words, I am not sure if we will ever have the empirical evidence of, what is the most effective CDT protocol. But if we now show you a few before and after pictures, and we have an extensive clinical experience, this should indeed convince even the most skeptic that CDT applied in the proper fashion is the best and most effective treatment for patients with lymphedema. Once again, remember that this is all about patient care. We owe it to our patient to give them the information about their treatment so that they, with your help, can make an educated decision. Your administrator and scheduling department needs to be educated why patients with lymphedema need to be accommodated differently from other patient groups. And if your administrator, supervisor, is more concerned about the bottom line than offering the highest quality lymphedema care possible, ask them one simple question. If the person you love most in this world, your spouse, your mother, your child, had lymphedema, would you not want for them to have the best, highest quality lymphedema care available? Would you refer them to a lymphedema therapy program that offers substandard lymphedema treatment? So I encourage you to evaluate your lymphedema therapy program and stand up for the patient's right to receive the best and most effective lymphedema therapy available.